disclosures that are relevant here. We all have these patients when we do Watchman procedures or any LLA occlusion. You see patients that have intracranial bleeds and they're referred to you for Watchman therapy, but your neurologist is going to say, sorry, I can't use any oral anticoagulation. Or you have someone who bleeds significantly and they GI bleeds, and again, same question comes up, can you somehow modify your protocol? So what do you do if you really can't have a patient who can't tolerate any anticoagulation? Now this is the protocol that, as far as I can tell, we're supposed to use. You might modify your aspirin therapy somewhat, but if you look at the criteria, this is what implanters should do. But the reality is, of course, different. When you look at especially the evolution registry and the Europeans, they adopted multiple different antiplatelet, anticoagulation therapies quite early, earlier than us probably. And you can see NOACs were used, just warfarin, just dual antiplatelet therapy, single or nothing. And you can see after 3 months, what came out, and you heard it before, is that there's one signal that if you use TEE and if you actually look for it, you will find in 3 to 4% maybe a thrombus on the device. Interestingly, it doesn't accumulate to exactly the same amount of strokes. So that led implanters to say, okay, well, if you have a thrombus, I can deal with it. It doesn't seem to be a stroke, so let's continue. And then if you look at the 1-year data, same registry, now focusing just on dual antiplatelet therapy because that makes kind of the most sense, right? So if you implant a device, you're using it in other devices too. You see that you have 4% risk of that device thrombus, but at the same time, again, about a 1% risk of ischemic strokes or TIAs in that area. Now, when you look at the evolution registry, you can see that, interestingly, so people have really early adapted to completely different medication regimens. So about 60% actually of the implanters in Europe decided not to use the recommended warfarin aspirin therapy. And in this paper here by Bergman, what the argument was is, well, you have certainly the thrombus buildup, you might have a couple strokes, but if you look at the risks of the patients that you're actually submitting the therapy to and where you make that specific decision that you don't want to put them in oral anticoagulation due to their risks, you still reduce their risks, right? So if you calculate out what their bleeding risk would have been, but if you do the Watchman device with your adjusted therapy, you still have less bleeding than expected, and you also have less strokes than expected. So the overall argument is, yeah, there's a little bit more risk, but you still help patients, so let's continue. And this is really what, if you look at this paper, I think it was mentioned before, Sondergaard here, if you put all the registries, clinical trials together, you can see that about only in 60% of the cases, warfarin and aspirin is used. Otherwise, people have already adapted to different therapies. And again, the number seems always to be the same, 3 to 4% risk of a thrombus on your device if you use anything but oral anticoagulation, in that sense, warfarin. But in this trial, at least, or this summary of trials and registry, there were no significant signals in regards to ischemic strokes, and there were also no signals in regards to higher bleeding rates. So that was good news. Now, if you look 1 year before that, and we saw the paper also presented earlier by a presenter, if you had the same paper done, and they did it, without these data from ACEP and evolution, it looked slightly different. So then in that paper, you had, again, the 3 to 4% risk of device thrombosis. But this time, when you did the analysis, it seemed like the ischemic stroke risk and all strokes were actually associated with thrombus on the device. So that was kind of a scary moment. They also, oops, too fast. They also had some predictors. So they said, okay, if you had, these are kind of the usual culprits in all of our devices that we're using. As you can see here, permanent atrial fibrillation, vascular disease, maybe even larger devices like it seems to be in TAVR now, lower EFs. But unfortunately, no matter how they looked, they couldn't give us a threshold. So they couldn't say, okay, 29 is bad or 33 is bad, and lower EF 25 is bad. Nothing is really predicting it, right? So you kind of have to do your own clinical judgment. If you look at this French center, Reaxeo registry, little less numbers, about half of them were Watchman devices. They actually had a higher device thrombus rate. It was 7 to 0.2%. And you can see that, again, nitinol cage here is the Watchman device and then a plug. People immediately adopted here. 60% of implanters used a completely different antiplatelet anticoagulation therapy, despite no recommendations in that regard. And then you had, again, 4 to 5% risk of thrombus just for the Watchman now, since we're talking mostly Watchman here in the US, on the Watchman device. But it seems, interestingly, if you put patients at least on something like antiplatelet therapy or the dual antiplatelet therapy, as you can see here, I think you can't see my cursor, but the third or fourth from the top, you can see that there was actually a protective effect of the antiplatelet therapy. But if you had a previous stroke, or if you had a high chest a previous stroke, that would be a predictor of thrombus formation. And then if you looked at the TIAs, you saw that if you had a thrombus or if you had vascular disease, you actually had a higher risk for a stroke. And if you had a thrombus on platelet therapy, you also had a higher risk of stroke. So there was, again, that signal that if you have a thrombus on your Watchman device, you might have a higher risk of stroke. So for me, it's slightly confusing. So what should I do with a patient? And obviously, we have limitations because there's not really a complete definition of what DRT is. And at the same time, how do you diagnose it? And some people even don't do the 45-day or 6 months follow-ups for the patients. So I think, as mentioned before, these are interesting and I think very, very important trials that are coming up, because all of them include something that was kind of sneaked in, I think. So you can use, for example, NOACs, DOACs after the implantation, which wasn't done before. ASAP2 is, of course, very important because it's going to show us in a really randomized fashion if the dual antiplatelet therapy is safe. We just have indications right now. And then again, in the option trial also, there is that option that people could use NOACs, DOACs after the implantation. So a lot of data, I think, are going to come out in addition to just the traditional aspirin warfarin therapy. And as a conclusion, I think we can say that overall, it seems that there is definitely more thrombus formation on the device, but it doesn't seem to accumulate into kind of like TIA strokes in all patients. There are some signals, some are not. But interestingly, if you look at the CE market, it already has now included in Europe that you can use alternative regimens. So dual antiplatelet therapy is now allowed in Europe after the implantation. So they are actually moving forward already, right, without actually ASAP2, for example. I think we can definitely say if you do single antiplatelet therapy, that probably shouldn't do that, yeah. And unfortunately, there are some predictors, but it doesn't really help you quite with the decision making. But the predictors that I showed you might sway you in one or the other direction based on the published data. Thank you.